All right, so chapter 13. I broke this up into two parts because chapter 13 is a pretty in-depth chapter. So there's a lot of information to cover in this chapter, so make yourself comfortable and we'll go ahead and get started. All right, so basically, a lot of the things that we can do are very beneficial as a paramedic, but the consequences of some of the things that we do and the choices that we make can be very detrimental to the patients that we're taking care of. So it's vital that we understand when it comes to medications that we do the right thing, that we understand the medications very well, we understand its effects, its side effects, what we intend for the medications to do, and what we don't want the medications to do. There's been many times when I myself would opt not to give a medication when it was somewhat indicated, but I've held back on that medication for fear of some of the side effects that may actually be worse than the reason why they called me to help them in the first place. So we need to take a lot of things into consideration when it comes to medications, and don't just haphazardly give medications or give medications because, hey, it's a cool thing to do. Also realize that pharmacology is a scientific study, so there's a lot of science that goes into this. We're not going to get too far off into the weeds in that, but it's going to feel like we did. But we're going to talk about a lot of information as it relates to medications and giving medications and pharmacology and all that kind of thing. But basically, pharmacology is the scientific study of how various substances interact with or to alter the function of living organisms. That's basically what pharmacology is, the true definition of it. To give a little bit of historical perspective on medication administration, most of the chemicals come from plants and animals, and these have been used for centuries. The Chinese are actually very good at this, herbal remedies and those kinds of things. The formal scientific study began in the late 17th and the early 18th centuries, so we really began to look at medications in a different way and how they can be positive, have a positive impact on our well-being. Some of these ancient remedies are still used today. Oftentimes people find it very hard to believe that we had moving pictures, we had videos and moving pictures before we had most of the antibiotics that we have today. Most of the medications and the life-saving things that we use today, we didn't have back when they had moving pictures in the 20s. A lot of this is still relatively new, and they're still developing and creating new things that we're able to use. And that's why it's vital that as a paramedic that you stay up to date and well informed about the medications that are on your truck and the medications that are out there. A lot of times we used evidence-based guidelines to assist us with providing pharmacological interventions. And through this evidence-based process, medications wind up undergoing an extensive testing and clinical trials to make sure that they work. Obviously, sometimes some medications still get through. Sometimes there's consequences of medications that we're not familiar with, or that are unforeseen, or they're just unsuspected. I remember a while back that there was an antibiotic and an antihistamine. Two common things. It was a respiratory antibiotic. I can't remember the name of the antibiotic or the antihistamine. The antibiotic is still on the market. The antihistamine is not. The problem was they discovered that if you prescribed the two of these together, the antibiotic and the antihistamine, it could be fatal in a high percentage. Well, unfortunately, that wasn't something that came to light in the clinical trials because they were really just testing the effects of the antibiotic and weren't necessarily focusing on its interactions with other medications. Sometimes it's not until those get out there on the market that we see a medication going over a wide swath of people, and we start to see individual disease processes that are really unrelated to the purpose of giving the medication start to be affected by that, and then it starts to cause problems. Of course, attorneys love that. You probably see all their commercials on TV. If you've taken this medication and died, call us. We'll sue them. That's the kind of deal that the kind of thing that they run. All right. So there's a huge regulatory body, of course, that regulates medications and it's, of course, the Food and Drug Administration, the FDA. And that act actually was started back in 1938. It seems like a long time ago, but in our nation's history, it's not all that long ago. Relatively short time. The FDA approves new medications and removes unsafe medications from the market. Not only do they approve those new medications, but they approve what their intended use is. You know, I remember when it was discovered that Wellbutrin is and one of the first SSRIs, this selective serotonin reuptake inhibitors that was used for treating depression. One of the side effects of that was the people that were taking Wellbutrin lost the urge to smoke. They quit smoking while they were taking Wellbutrin. It was kind of an unintended consequence, so physicians recognized that, and they began prescribing Wellbutrin to people that wanted to stop smoking. The problem was that drug was not approved for that use by the FDA. So physicians can actually get in trouble for prescribing medications for uses that are not approved by the FDA. So they have to be careful with that. The FDA kind of reined that in, and some new medications came out on the market. And I think they have ultimately allowed Wellbutrin to be prescribed in that way. Obviously, they've also developed some new medications, so Wellbutrin isn't used for that. The problem with using an antidepressant type of a drug, anything that alters the brain chemistry, it increases the risk of suicide rates and those types of things, even in healthy people without depression. They run the risk of it increasing suicidal tendencies and those kinds of things. So anytime somebody's taking one of those types of medications, even the new, I can't even think of the name of the new medication that's out there to quit smoking, even that medication runs a risk of depression, anxiety, suicide, and that kind of thing. So it's vital that whenever somebody's taking these medications, they take them as prescribed and for their intended use. And that's why the FDA is in place for that, because it can actually be harmful if we're taking medications for the wrong reasons. Even if your doctor prescribes them, it's got to be done for the right reasons. Okay? So the approval process for a new medication usually takes years, sometimes 10 to 15 to 20 years. Some of them never actually get off of the counter. They never get off the table. They're never used. They never get approval. Like I just talked about, some medications are used for off-label purposes. This is not approved by the FDA. And the doses may be different than the recommended doses that are approved by the FDA, or by a route that's not approved by the FDA. So there's some problems within this, and typically physicians don't do these types of things, but sometimes they do if they know that that drug is on its way to being approved for that purpose, or there's a really good likelihood that it's going to be approved for that purpose. But sometimes if you walk into your physician and you go, hey, I want drug X to treat this, I've heard it works, your physician may go, I can't prescribe you that drug for that because it's intended to be used for this. And the FDA has a whole lot more regulatory power in that than what people realize. There's also the Controlled Substance Act of 1970. Recently, this Controlled Substance Act has caused a lot of problems for EMS providers, and that's not really talked about in your book. But what this does is it classifies medications with the potential for abuse into 5 categories or schedules. So Schedule 1 through 5. Schedule 1 drugs, there's no medical purpose for those, and they're absolutely not legal for medical purposes. The one argument is, of course, marijuana. We're seeing more and more medical uses for marijuana. I honestly suspect that drug at some point in time within my lifetime will be nationwide approved. It'll come off of the Schedule 1 and probably move down to a Schedule 2, perhaps even a Schedule 3. I wouldn't mind if a Schedule 4 wouldn't be completely out of the question, moving it way down the list, because there are some medical uses, and really the dangers and the side effects, the addiction rates and those kind of things are not as high as LSD and heroin like they've got listed up there at Schedule 1. Schedule 2 has a very high potential for abuse, such as cocaine and fentanyl and that kind of stuff. It's funny because most people think that they find it ironic that cocaine is a Schedule 2 drug and not a Schedule 1. There is some medical uses for cocaine. They actually use that in some to cause some vasoconstriction to help stop some bleeding in mucous membranes and those kinds of things. I know it seems kind of odd, but they do. Ritalin, Ritalin's a Schedule 2. It's way up the list. And then you've got your Schedule 3s, hydrocodone, Vicodin, Tylenol 3s, ketamine, those kinds of things. Schedule 4 is your Valiums, Ativans, that kind of stuff. 4, cough medicines, narcotic cough medicines. Sometimes people take the Schedule 5s, Schedule 5s too lightly with those narcotic cough medicines. There's been several fatalities of people just kind of plugging that like you do over-the-counter cough medicine, and it contains codeine. They lay down, go to sleep, stop breathing because of the narcotic in it. So they can be very dangerous. But the Controlled Substance Act of 1970 made those categories. It also placed some regulations about how narcotics are controlled and how they're taken care of and how they're handled. That they have to be under lock and key. Certain ones have to be under lock and key. Anything is Schedule 3, Schedule 2 and 3 have to be under 2 locks. Schedule 1 drugs, you're not going to have them. They're not legal for you to have. Some states it is legal for marijuana. There's still some conjecture about that. Oklahoma is not one of those states yet. But the problem is, actually, it's not. It may be solved by now. I take that back. I was going to say it wasn't solved. The Controlled Substance Act of 1970 never allowed for controlled drugs to be carried in an ambulance. People may find that odd nowadays because, we've been carrying controlled drugs in the ambulance for years. I've been doing this for 25 years and we've always had controlled drugs in the ambulance. The problem was, it was never written into the Act of 1970. So it's something that the DEA, the Drug Enforcement Agency at the federal level, just kind of let slide. And there was really no regulation for that. There was really no control over that, no regulation for that. And abuse actually has been pretty rampant because of that, abuse by providers, because there's not the control mechanisms in place. The good news is, actually the bad news is the DEA this last year in 2016 said, hey, look, if something isn't done, we're going to enforce the law of the Controlled Substance Act of 1970 to the letter, which means no narcotics, none of that stuff, no controlled substances in ambulances. So that was their game plan. That was what they were going to do, but they gave everybody plenty of lead time. I think they may have started it back in 2015 saying that they were going to do this. Some laws were drafted, written, all that kind of stuff. Well, and it's the Controlled Substance Act of, or Patient Access to Emergency Medications Act or something like that. I can't remember the exact name of it. It passed the House, recently passed the Senate, and as of last week, which, today is, November 12th or 13th, as of today, I think it was sitting on the president's desk, but he was overseas. But it may actually, by default go into law. If he doesn't veto it, in 10 days it goes into law. Well, he had no intention of vetoing it, so it may already be into law, or it's just a couple of days out from actually being law, to where that, yes, we will be able to legally carry controlled substance in our ambulances. Seems odd that it hasn't been legal this whole time, but it has not. So now it's going to be legal, but look for some new changes, some regulatory changes in the way that those medications are handled at your ambulance service. I realize you're not a paramedic yet, but you're probably going to hear some paramedics groveling about that, or some directors groveling about, oh, this new law, they're making us do this. Why we haven't had to do this before? Well, it's because most people didn't realize that we've been doing it wrong, doing it illegally this whole time. So. Sources of medications comes from a variety of sources: plants, animals, minerals, microorganisms. Some of them are synthetic. A lot of the narcotics that we're using nowadays are synthetic. Some of them are semi-synthetic, so it's got some plant chemicals in it and then some chemically modified things in it, that kind of stuff. So a lot of different sources for medications where these things come from. The companies that manufacture these, they control the concentration, the purity, preservatives, and other ingredients. I find it interesting, and I always kind of plug this in there. If you smoke or use smokeless tobacco, what's interesting is the Companies that manufacture that actually control the concentration of nicotine that your cigarettes or snuff or chewing tobacco or whatever it is you're using contains. It's not natural. It's not 100% natural. It's not like it comes from the field and that is the natural nicotine content. They actually regulate the nicotine content themselves, so basically making sure that everybody gets the right amount of nicotine to satisfy their habit. I know it sounds kind of underhanded, right? But that's what they do. Perfectly legal too, by the way. But pharmaceutical companies also do that with their medications that they create and they manufacture. All medications must have a manufacturing lot number and an expiration date clearly printed on their label. Okay? And that's why it's important that we keep all medications in their original containers or in their original, what they came in. Otherwise, if we have to draw it up in a syringe and we don't use it, we can't put it back in the cabinet. If we draw it up in a syringe and we don't use it for that patient, we have to discard it, get rid of it. So it has to be in its original container. All right, and medications come in a variety of different forms. Most of you guys are probably very familiar with most of these, if not all of them. Capsules, tablets, powders. It used to be pretty common for a form of aspirin was BC powder. I don't know how many of you guys have ever seen that, but you would actually snort it kind of like cocaine. I remember the first time I seen somebody use BC powder and they snorted it, and it was white, a white powdery substance, and they're snorting this, and I'm like, I was appalled. I mean, I was at work, and I was appalled. I'm thinking, what are they doing? They're snorting cocaine right in front of me. As it turned out, it was BC powder, so it really wasn't a big deal. We still see some of those, not necessarily snorted, but maybe they're added to a concentration, mixed with a solution in a liquid or that kind of thing. Droplets such as inhalers or nebulizers, those types of things. Perennial solutions, new term right there, perennial solutions, when we're talking about, and I'm probably not saying it right, but I always call it perennial. Those solutions are actually solutions that we inject, either into tissues or blood vessels or organs or those kinds of things that we inject into it with a needle. Skin preparation such as topical things, ointments, gels, patches, that. Suppositories, you don't want to know where they go if you don't already know. Liquids, liquid medications that we drink, typically those are for the younger ones, infants and children. And of course there's inhalers. I guess I'm misunderstood that droplets, I guess, are for nasal, I guess. Neosynephrine, Nafrin, and those kinds of things. And the inhalers and sprays are down there for respiratory. So a lot of different forms that medications come in. What we need to know about medications is we need to know the chemical name. It's the name that was used during the development. That's not really critical because that name can get really wordy. It's that, when you're watching a commercial about drugs or a drug or a medication, and it says, it gives you the name of this drug and then it gives this really weird name underneath it. Sometimes that's the generic name. Sometimes it's the chemical name. Usually the chemical name is a really weird, chemically sounding name. You know that it's a chemical engineer that came up with that name. So then there's this generic name. All of them have a generic name. This helps with consistency and it avoids duplication. And it usually includes some sort of a stem word. If you think back to medical terminology, it's got some sort of a stem word. For instance, you have Advil, Tylenol, different types of pain medications, and that's probably not a good example, but some of them contain acetaminophen, some of them contain ibuprofen and that kind of thing, and then you have generics that is either acetaminophen or ibuprofen is what it says on the label. Well, what that helps is, what the generic name helps with is that consistency element, meaning if you have all of these pain medications, over-the-counter pain medications on a shelf, and you're looking at them, and you see one's Tylenol, one's something else, and one's a generic, and they all say ibuprofen underneath the trade name, then you know that that's the same medication. They're all the same medication, essentially. And I say trade name, I mean brand name. That's the proprietary name chosen by the manufacturer. That's the big name that you're going to hear, Tylenol. Which Tylenol is really ibuprofen. Or another example is Lasix. Lasix is a brand name. the generic name is actually furosemide. So you can have another company putting out a brand name of Lasix, but it's all furosemide. It's all the same thing. So brand names, generic names are important. It gets a little confusing for new paramedics because sometimes we'll call it by the brand name, sometimes we'll call it by the generic name. It's really important that you understand both. And you'll kind of get it. You'll start putting the two of them together. It'll take a little bit of time, but you'll get there. All right? Also, there's this gives an example of a chemical name. See, there's that weird whatever, whatever acid. And then there's the generic name is furosemide, brand name is Lasix. And then we have this tall man lettering that gives us the root word. Remember, it talked about the root word, diphenhydramine and dimenhydrinate. That kind of gives us that root part of that word that kind of helps us distinguish where, what type of medication that is or what classification that it's in. Don't sweat that right now. You'll start to understand that a little bit more later, and that is not super critical that you understand that, okay? Just a little bit of information. I just don't want you to get too caught up in feeling like you have to understand that. All right? All right, so when you're considering a source for medication information, such as physician's desk reference, your pocket field guide, online sources, those kinds of things, electronic or whatever, consider the source, really. How reliable is that source? Is that source even ever heard of? Have you ever heard of that source? Is it reliable? Is it accurate? Is it good information? Online you got WebMD, Medications RX, or there's all kinds of different ones on there. So make sure that you're getting your information from a very reliable source. Check multiple sources and make sure things line out. They should. Whatever information you get about 40 milligram Lasix from one source should be the same as 40 milligram furosemide from another source. They should be the same. It's the same drug, same interaction, same things. It does the same stuff. You also want to try to find a source that has some in-depth information. You want to know what we call the pharmacokinetics, how that drug works within the body. How is it? How does it work? How is it eliminated? How does the body deal with that substance within the body? So you want to have some in-depth information and not just kind of surface or light information about a particular drug. How accessible is that? There's a lot of electronic sources that you can download an app for your phone that are very accessible and very reliable, and they're free. The availability of updates and how much material is going to be used, the size of these things. A physician's desk reference, the regular book of that thing it's a book about 5 or 6 inches or 4 or 5 inches thick, and it's the size of a regular book. So it's a lot of information. It's not the kind of thing that you're going to carry around with you. The good thing is most of the time, what I usually harp on paramedic students to do is know the class or category of the medication. And I kind of put the class and the category together, meaning if you know that a particular drug belongs to, say, the antidysrhythmic group, that it treats heart rhythm malfunctions, if it belongs to that antidysrhythmic group, and you know that amiodarone belongs in the antidysrhythmia group, and you pick up another drug and you're like, I've never heard of this drug before, what is it? And you look at the classification of it and you see, oh, it's an antidysrhythmic. You're like, oh, this is probably a heart drug to treat some kind of heart rhythm abnormality. Now, that's not going to tell you a ton of information about that particular drug, but it is going to narrow it down. You're not going to go, is this a diabetic drug, or is this a kidney drug, or whatever. You know that it's something related to heart dysrhythmias. So it kind of helps you classify that drug or put that drug in a place in your brain where you can kind of process it a little bit better. So classifications of drugs are important to learn and understand. And don't get caught up in the semantics of drug classifications. You may have, and I'm trying to think of a good example, and a drug may belong in different classes too. So some drugs that are antihypertensive drugs may also be diuretics. All right? So Lasix and lower someone's blood pressure means antihypertensive, but it's also a diuretic, meaning makes you make water. So it can belong to more than one category, or classification. So try not to get caught up too much in the semantics and go, does this one go here or does it go here? Well, the answer may be it may go to both. Understand those classifications and it'll help you immensely. Okay? This gives a couple of medication profile sources, USNF and the physician's desk reference. Also, this USP-NF is, that medication is, it's registered in the U.S. Pharmacopoeia, and that's what USP means. So when you look at a medication, any medication that you see manufactured and sold in the United States is going to have on the label on it somewhere something related to USP. It'll tell you USP, and there may be, I could be wrong, but I'm thinking there's probably a number with it that says this is registered in the U.S. Pharmacopoeia, and here's its registration number. So that you know that medication is legit. Not usually something that we have to worry about, because our medications, we know that they're from the right source. But the DEA walks in and says, hey, where are you buying your meds, and are they approved? Well, yeah, right here it says it is. All right, manufacturers have to provide packaging inserts that include dosing, route of administration, contraindications, and adverse effects. It's a great source of medication information. So if you open a box of atropine at your work, there should be a medication insert in it. Okay? So these inserts should be there. Maybe not all of them will have an insert, but you should be able to find that. You should be able to go online to the manufacturer's website and find that insert, to find that information on it. That's intended to help providers, pharmacists, and even the user of that medication, if you're taking that medication yourself, so you have information about it. Some hospitals actually are able to compile formularities specific to their needs. Some pharmacies are actually able to do that too. If you look at a pharmacy, if you see their sign or whatever and it says it's a compounding pharmacy, it means that they're actually able to create their own formularities of certain medications. Meaning, if a doctor says, I want you to take this drug and mix it together and give it to this patient, that particular pharmacy is capable of being able to do that within certain restrictions and limitations that are allowed by law. We won't get into that, but the AMA drug evaluations provide some detail about that, but there's some regulations and there's some things that they have to follow when they're doing that. But some hospital pharmacies and commercial pharmacies that are have their own shingle and their own place of business, are able to create their own formulas according to a physician's orders, not just hey, we're going to start mixing stuff together and try to cure cancer. No, they're not going to be able to do that. Excuse me. The medications are classified according to the recommendations that fall back to the amount of evidence that supports its use in that particular area. So whenever you're looking at a medication and the FDA has said, or not the FDA, the AHA, it's not the American Heart Association, but they're going to classify these medications according to, it can be used to treat this thing, this thing, this thing, this thing, and this thing, and they're going to say when you're treating this thing, the first thing on the list, it's going to say, hey, it's a class 1. It means there's a lot of evidence supporting its use for treating this. And you may get all the way down to, hey, it's approved for treating, toenail fungus, but it's a class 2B. It's not much evidence supporting that it'll work, but you can use it for that. Basically what it's saying. And then you get down to class 3 that says, hey, there's no evidence that supports its use. And then there may be some that they're doing some additional research on using it for a particular thing. I think that's kind of how the loophole happened with Wellbutrin, and they're using it to treat, smoking cessation, is that they kind of placed it in this class 2B category. There's weak evidence supporting that it may actually help people stop smoking. But that's how they classify those drugs, the use of those drugs. Medication storage, you must make sure that we provide adequate protection. We should never store medications in direct sunlight, or they can be in direct sunlight. We've got to protect them from excessive heat and freezing. We got to be able to get to them. Physical damage, they're rattling and bouncing around in the back of an ambulance. It should be in protective bins. Should be able to quickly and accurately identify them. So there's a lot of things that kind of come into play here. The problem is medications get expensive. It's one of the more expensive things in EMS that we have to deal with, because if we don't use a medication on a patient, then we have to throw it out. And we get zero money back when we have to throw out a medication. So that's just money literally going in the trash. If we happen to use it on a patient, which is unfortunate for the patient, when we use it on a patient, we can get reimbursed from their health insurance. But the problem is these things can be supplied in a variety of different ways. Oftentimes employers will look out there and try to find ways that they can buy it that's more efficient and effective, that ultimately winds up being cheaper, which means this month the Lasix is packaged in a vial. Next month the Lasix is packaged in an ampule. The month after that, holy cow, we got a special deal and they're all in pre-filled syringes. So it all just kind of depends where they buy it from. It can be packaged differently in different doses and different concentrations and a wide variety of looks and feels. And most of you guys have probably noticed that, or heard the paramedic say something about, oh, hey, it's a different packaging for this, and it looks a little different, or the box is a different color, or something's different about it. Just be ready for that and realize that it's probably more a cost-saving measure. Sometimes, though, some employees are like, no, we like how this is supplied. Or sometimes medical directors step in and go, no, I only want them to have it supplied like this. I want to take out as many chances for error as possible. So make sure when we store our medications, we store them in a way that is cost-saving and effective and that protects them. And like I said here, extreme temperatures, physical damage, direct sunlight are all big no-nos when we're trying to store medications. Controlled substances require additional security. Most of the time, they require two locked doors, two locked things. And the ambulance doors don't count as locked because they have to be locked all the time except for when we're getting in there to get a medication out. So it has to be behind two locks at all times. If you lock the ambulance doors, that would count as the third lock. So you kind of get the point. Additional record keeping is required. Those have to be checked as shift change happens, as a different medic comes on. Different medics leave, checked on, checked off. When you use it, how you disposed of it, and that kind of thing with witnesses and all that. My best advice that I can give you when it comes to controlled substances, don't take a chance. Goofing up, doing something wrong, being a stand-up person and just making a silly mistake, being lazy or not doing something the way that you should, cutting a corner, can end your career. Don't mess around with controlled substances. Follow the prescribed procedure that wherever you work has. Follow it to the letter. Don't take chances on it. Don't trust the other guy. Don't say, oh man, I've known old so-and-so for years. He's a good guy. He'd never do that. So I'm just going to not worry about it this one time. Well, guess what? That one time may be the one time that ends your career because it's got your name on it, not his or hers. So keep that in mind. I've known a lot of medics that have wound up with a drug addiction problem that were absolutely great, amazing medics, wonderful people. It ended their career, and few of them it ended their life. It's a tough thing to deal with for them and their families, but they get desperate. They get desperate, and your friendship will mean less and less the more desperate they get. Okay? Every last milligram, I don't know why it says milliliter, I should say millimeter, milligram needs to be documented. This is very, very true of controlled substances. And like I said, we have to take care of the controlled substances very well. Most of the controlled substances, when we have them in our truck, they have some sort of anti-tampering device. So make sure you inspect the vials and all that. I'm telling you, people that are going to use that stuff, they get desperate, they'll do all kinds of things, and they'll try to do all kinds of things, literally breaking an ampule open, stealing the drug out of it, and taking super glue and gluing the ampule back together with saline in it. If you don't look closely, you don't notice it. You don't notice that those things have been tampered with. So when you check the drugs in or check the medications in at the beginning of your shift, or check them out at the end of your shift, make sure that you're physically picking them up and looking at them, and that those seals and those protective measures haven't been tampered with. And if they are, get a supervisor, your director, report it immediately. Make sure that you're not on the hook for that. All right. So now let's get in some of the the physiology of pharmacology. Well, that's some fun words. Basically, the purpose of why we give medications is we want to give them so that we can produce a desired effect in the body, typically. Sometimes that desired effect is to stop something else going on, and it's not actually to induce something else to happen. It's more to stop something that is currently happening. Oftentimes that's what we do with the medications that we give is we're not trying to make something happen, we're trying to stop something from happening, but that is the desired effect that we're looking for in the body. The pharmacodynamics is the alteration of a function or process of the body as the medication is administered. And remember, any medication can have toxic effects. Very, very few medications that we carry or that we're allowed to carry don't have some kind of a toxic effect. Ironically enough, the one that we carry that probably doesn't have a toxic effect that I can think right off the top of my head is Benadryl. I don't think it's possible to overdose on Benadryl. Don't try it, but that's one of the few. But some of them, many of them will have toxic effects. Some of them have toxic effects at therapeutic doses. It seems odd to say that. I'll give you a perfect example of a medication that has a toxic effect at normal approved doses. Chemotherapy. Chemotherapy, radiation therapy have toxic effects on the body at normal therapeutic doses. People's hair fall out. They get sick, violently sick. That's the therapeutic doses that are having toxic effects on the body. But it's the ends is supposed to justify the means. So remember, when we're giving a drug to somebody or medication to somebody, we are giving them what equates to poison. In one way or another, it's poison. If we don't control how we give it to them and the dosage and the manner and the way that we give it to them, it can be toxic. Like any other poison, it can be as toxic as hemlock if we don't give it to them properly. Interestingly enough, one of the drugs that we give is called atropine. Atropine comes from the belladonna plant. The belladonna plant is a highly toxic and poisonous plant that will kill you if you eat a leaf off of it. But we use that plant to create a medication to do a desired effect. But if we give that medication to the wrong patient at the wrong time, we will kill them. It can have a very toxic effect. So make sure you know what you're doing, you understand your drugs, you understand the reason why that you're giving it to them, and you're not just following an algorithm. You're not just going down the list and you go, well, they've got this, and they've got this, so I guess I'm supposed to give this. Don't do that. Use your head. Use your head. Think your way through this. Make sure that you're doing the right thing because these drugs can kill people. So when we give a medication, there's ways that we give a medication, the ways that medication is done in the body. So that process of medication administration is either through absorption, distribution, biotransformation, or elimination. So the process, the way that we give a medication, we give them a medication that's absorbed into the body. Whether we inject it in a needle, we stick it on the skin, we squirt it in their nose, they inhale it in their lungs, we give them suppository, it's absorbed into the body. And ironically enough, people kind of giggle about suppositories and the rectal route of giving medications. It is one of the more potent routes. Actually, there have been people that have died, alcoholics that have died by being so desperate for alcohol that they give themselves, I don't even want to know how they do it, but they give themselves alcohol rectally, like regular alcohol. And it would only take maybe a shot, or what we would consider a shot glass of alcohol to kill you. Because the thing is when you give those medications rectally, they're not filtered through the liver before they hit the bloodstream. So the problem is they go directly into the body system and they wreak havoc in the body system. So rectal route, there's only certain medications that we can do that with. So route does matter. So route matters with absorption as well. If we give an injection into a vein, it's going to get in the system faster than if we put a patch on someone's skin. So absorption matters because that affects distribution. How is it distributed throughout the body? Is it distributed into the tissues? Do we need to affect the brain? Do we need to affect neurotransmitters or those types of things? How is it distributed? How does it get to where it needs to affect? And then how is it biotransformed? Is the biotransformation process one of those processes that, hey, it's transformed into something completely inert? Basically, how is that drug broken down and eliminated from the body, right? So how is this drug broken down? Is it broken down in such a way that it becomes completely non-toxic? Or is it broken down in such a way that it leaves some kind of toxic elements to it? To where that if we took an overabundance of that drug, when it starts to biotransform, then we start to have some toxic effects. Those are the things that we have to watch out for. Those are the things we have to be cautious about. Biotransformation, distribution, and absorption, and even elimination, all of these categories can be affected by age or illnesses or different things that are going on with a particular person. Of course, elimination is how is that drug eliminated from the body? Is it the liver? Is it the kidneys? Those kinds of things. Does it stay in the cells, the fat cells, that can redistribute that later? There's all kinds of different things that can happen in the body. The pharmacokinetics is the action of the body on the medication. So how is that process? We can kind of go back to biotransformation and elimination when we talk about the pharmacokinetics, is how does the body handle that medication? How is it, when the body receives that medication, what's it do with it? How does it start to break it down? How does it work within the body? How is it eliminated? Where does it go? What does it do? What's it break down into? That's what we're talking about with the pharmacokinetics, and those are some things that are important to know because sometimes it's the breaking down of that medication that will cause patients problems on down the road. So sometimes we might decide to withhold a particular medication from a patient that really the medication is technically indicated, but we might withhold it from them and go, you know what, I realize this might help them right now, but a day and a half or 2 days from now when they're trying to recover in the hospital, this is going to make things worse. I'm not going to give it to them. Now, you may get to the emergency room and the doctor in the ER may give it to them, but they may give it to them with something else or do something else or with the specific purpose of doing something along the way. They don't always think that just because the way that we do it in the pre-hospital setting is the way that they should do it in the hospital. Nothing can be further from the truth. Hang out in the hospital for a while, which you guys will get a chance to do, but hang out in the hospital with some of these critical care docs, and you'll see them do some things that will just freak you out. A friend of mine was going through some cancer treatment, and she had a reaction to the chemotherapy that they were giving her, and what happened was, with this reaction, they started giving her Benadryl. And our normal dose for Benadryl is 25 to 50 milligrams for an adult, right? They gave her like 800 milligrams of Benadryl in one dose right off the bat. And then they told her she needed to take like 200 milligrams, 200 or 400 milligrams of Benadryl every 2 hours for the next 24 hours or something crazy like that. And I was thinking, oh my gosh, they're going to kill her. But as it turns out, no, that's actually standard treatment. So some of the things that we do in the pre-hospital setting, we do them in the way that we do them for the purpose that we're doing them for. When they get into the hospital, they do things very, very differently for the same or even different purposes. Okay? So just realize that you're going to see a disconnect there, and it's intentional. There should be a disconnect. All right? So, pharmacodynamics. What we're dealing with when we give somebody a medication is we're trying to hit a receptor site. We're trying to There's a receptor, there's a target, there's something that we're trying to trigger, a switch that we're trying to flip. So that's what we're doing when we give them this medication. And these switches are flipped either by endogenous chemicals, chemicals that are in the body, right? If you think back to anatomy, sometimes the body sends out chemical messengers or these chemicals out through the body that says, hey, you do this. Hey, you organ, do this, or you cell, turn this on or turn that off. Sometimes those chemicals are internally. The body sends out those messengers. Sometimes they're externally. Sometimes we give a medication that triggers the release of chemicals that will cause that to happen internally. So we give an exogenous medication to cause an endogenous chemical reaction. All right? Oftentimes, though, the medications that we give are exogenous chemicals. They're chemicals that we give from the outside of the body that literally target that specific area. Some medications that we give, though, realize they may not target that specific area, but that may be a cascading effect that gets to where we're trying to be. All right? So when a medication binds with the receptor site, it does one of a few things. It either opens up channels that allow ions to pass into the cell walls. It can either be opened or closed. Remember we talked about, in anatomy and physiology, those ion channels, those gated channels, and what causes them to open or close, acetylcholine and all those kinds of things. Well, we can give medications that cause those same ion channels to either open or close, either stay open or stay closed, or make it more difficult for them to open or close. It might slow the opening or the closing of those just because we start to take up some of those channels and kind of plug things up, right? So our goal may not be to completely stop something from happening, but to slow it down. Say we've got a really fast heart rate, and we want to slow things down, and we give somebody verapamil, which is a calcium channel blocker. So we give them this calcium channel blocker to block the calcium channels from working, from allowing calcium to flow in or out of the cell. It actually works at the motor end plate. Remember where calcium flows into that motor end plate and releases acetylcholine? Well, we limit the inflow of calcium into that motor end plate, and it's going to release less acetylcholine, which is going to cause less stimulation, and we're primarily affecting the heart. Of course, calcium also is going to have some effects on the blood vessels as well. It'll cause a little bit of relaxation in the blood vessels, it'll lower blood pressure and that kind of thing. But that's what we're doing with calcium, is we're affecting those ion channels. So what we're doing with these medications is we're trying to affect these receptors. Some of them will have a biochemical messenger that becomes activated. So, like I said, we may give a medication, it may not necessarily go right to the receptor, but it may cause a chemical reaction that causes a messenger to go hit that receptor. Some of them will cause normal cell function to stop. Some of them will cause normal, even abnormal cell function to start. It's kind of odd that we would use medications that would cause abnormal cell function, but we do. One of the drugs that we give is adenosine. It's one of them that we use to cause abnormal cell function. We give somebody adenosine, and when it works right, their heart stops beating. It stops all heartbeat functions. It just stops. The good news is it only stops for 3 or 4 or 5 seconds, and then everything kicks in. We use it to do that, to kind of reset the heart for what it's doing. So that's one of the medications that we're going to cause the cell to function abnormally. But these are working on receptor sites. Think of medications as primarily acting on receptor sites or causing a reaction on receptor sites. So that's kind of the principles of the pharmacodynamics of medications. Once they bind with that receptor site, let's see, where are we going with this? Medications bind with a particular receptor site on the target cells. Some of the newer medications only hit specific receptor sites. Early medications that were created were kind of a shotgun effect, and it hit the receptor site, mainly hit that receptor site, but it still had some side effects of hitting some other receptor site. Well, they've gotten better with their medication development, so the newer medications are actually getting really good at only targeting those specific receptor sites. I remember when some medications that when they first come out with blood pressure medications called ACE inhibitors, acetylcholinesterase inhibitors. Is that right? No. Angiotensin converting enzyme inhibitors. When they first come out with those were a little more broad spectrum. Now the newer ones that they come out with are very, very focused in the inhibiting of that, converting of that enzyme from angiotensin 1 to angiotensin 2, which raises the blood pressure. So these medications, the newer medications, are very good about being a lot more specific about what they target, less side effects. But sometimes it increases the potency of these medications too because they're much more specific. So we've got to be careful with that. Two types of medications that directly affect cellular activity by binding with receptor sites are agonists and antagonists. So when we think of agonist and antagonist, agonists initiate or alter the activity, antagonists prevent the chemicals from reaching receptor sites. So basically an agonist is going to stimulate a cell to do something, an antagonist is going to block stimulation of that cell from doing something. There's a lot of new terms in here. Some of the terms actually mean the same thing, but we use different words for different instances. I know it's very confusing, but hang on. So agonist is going to initiate. It's going to cause it to happen on a cell. Antagonist is going to stop it or prevent it from happening. Multiple instances of why we would want to do that. We have cells that are doing something a little hyperactively. We're going to antagonize them. We're going to stop them. We have cells that aren't doing enough and need to be kind of boosted. Then we're going to agonize them. We're going to push them along. We're going to make them go. We're going to force them to do. Okay? So those are the two types of effects that we have on the cells. And we can kind of see that. This diagram's pretty good. This is normal. Before the drug over here on the left, if we give an agonist, you see the agonist, it's different. It's a different color. That's how they're kind of letting you know, hey, it's a different color. But what they're doing is we only see two of the natural chemicals in the center one there, two of the little green ones, two of the natural ones. So there's not enough there to stimulate this cell. So we give a medication, and that's these red capsules or these red things there that gives more of that particular chemical in that area, and it causes that plugs into the receptor sites and causes something to happen, right? An antagonist, on the other hand, does just the opposite of that. Basically, it goes in there and plugs up that receptor site, so the normal chemical can't get to the receptor, so it blocks it. So it blocks that cellular activity. Now, I know what you're thinking. That's got to be bad to block cellular activity. Well, we typically do that in doses that's therapeutic, right? So we're going to do that with just enough medication to get the desired effect. Most of the time, we recommend that with medications that do that have that effect, we titrate those medications. We do what we call titrating. We give them a little bit, see what happens, give them a little bit more, see what happens, and we still haven't even given them the normal dose yet. Maybe we've given them a half or a fourth of the normal dose, and we're working our way up to find that therapeutic margin where we need to be. So that's what we're doing when we're giving an antagonist drug, and that's typically why the drug dosing is so specific with that, because if we give them too much of that, then we may block all the receptor sites, completely shut down cellular activity, and if it relates to the heart, we may kill them. The heart may stop, and we may not be able to get it going again because of that antagonist drug that we've got in there. So these agonist medications, they have a very high affinity, which is their ability for them to bind with a particular receptor site. When they bind with that site, they're going to cause that cell to react in its normal way. So that's an agonist. Once there's enough of the agonist in there, that cell will reach threshold. It's that level at which the initiation of the alteration of cell activity is going to begin. And the more we increase the concentrations of that agonist chemical, the more the effects are going to be seen. So it's going to increase the effects. When all the receptor sites become occupied, then we see a full effect and its maximum potential is reached. So the maximum amount of cell activity is reached. The potency of an agonist has to do with the concentration of the medication that is required to cause that cellular response. As the potency increases, the concentration of dose typically decreases. An example of that is morphine versus fentanyl, whereas I believe fentanyl is 10 or 100 times more potent than morphine. So the dosage for fentanyl is a lot lower than morphine. It's unusual for us to give 10, 15, 20 milligrams of morphine to someone having chest pain, and they still stay very conscious. Whereas it would be highly unusual and probably fatal if we gave that much fentanyl to somebody. So that dosage is going to be, instead of measured in milligrams, it's probably going to be measured in lower dosages than that. So the more potent a medication becomes, the lower the dose that we're going to give is. But it makes it much more highly effective. The efficiency is the ability to initiate or alter the cell activity in a therapeutic or desired manner. So how well does that drug work? Ironically enough, the narcotic medications that we give for pain, the reason why they're so highly addictive is actually a side effect of the medication and not what its intended purpose is. Its intended purpose is to stop pain, to alleviate pain. Well, the problem is when that drug occupies those pain receptors on the on our body, with the pain sensors, the nerves that sense pain. When it occupies those, it also occupies some of them in the brain that are associated with pleasure and relaxation and those kinds of things, or at least it suppresses the others and allows those to take over. So that's why that drug is actually highly addictive. It does its job, it works, so it is efficient, but there are some side effects to it that we need to be aware of. All right, so antagonist medications bind with the receptor site to prevent that cellular activity from happening. They stop or inhibit normal cellular activity. They also can treat some harmful agonist effects of exogenous medication. So if somebody's overdosed on something or accidentally taken too much of a particular medication, don't always think of an overdose as something that somebody's done intentionally. A lot of overdoses happen purely by accident, and it's not always drug addicts that overdose. There are some competitive antagonists that temporarily bind with cellular receptor sites. Its efficiency is related to its concentration near the receptor sites and its affinity to that compared to the affinity of the other agonist chemicals that are present. So they start to be competitive for those receptor sites, and it all just depends on how great the affinity for that is. Probably the best example that I can give, we all know that carbon monoxide poisoning or carbon monoxide gas is very, very dangerous to humans. Why is that? Well, it's because carbon monoxide has a much higher affinity, or red blood cells, hemoglobin on red blood cells, has a much higher affinity for carbon monoxide than it does oxygen, meaning it likes carbon monoxide much more, it fits better than oxygen does on those hemoglobin. Well, that's what we're talking about is the same thing here, is when there's a competitive antagonist. Sometimes, no matter what we do, as in the case with carbon monoxide, no matter what we do, we can't fix that. We can't fix that competition in there. In the case of carbon monoxide, which is not really receptor related, but it kind of gives you an idea, that's going to take a hyperbaric chamber to fix, in big cases. So there may be some competition going on there at the receptor site. There's also some non-competitive antagonists that permanently bind. Basically, there's no competition there, so they just bind up and they're like, hey, we're here and we're staying. And it'll continue those effects until a new receptor site or cells are created. Basically, permanently blocked. Have to create new cells or new receptor sites for anything to happen. It can't be overcome by increasing doses of agonists or anything like that. It's blocked. It's stopped. It's not going to happen. So, no matter what you do. There are some partial agonist chemicals that bind to receptor sites, but don't cause as much cellular activity as a true agonist would. They have a lower efficiency than the other agonist chemicals do, but sometimes that's a good thing. For instance, one of the ways that we treat, I can't remember it now. Sometimes we'll use medications in the pre-hospital setting to treat things. We'll call into the doc in the ER and they'll go, give them this, this, and this, and you're like, but it's antifreeze overdose or something like that. And they're like, yeah, you give them this, this, and this. Well, why would I do that? Well, it's because there is some benefit. There's a partial benefit because of partial agonistic effects that a drug may have that is really kind of a side effect or a byproduct of that that's going to help with another situation. Just kind of happens to be that deal with some of them. There are some alternative mechanisms for drug actions. Some medications can alter cell function without actually working on the receptors. They're mainly designed to engineer some microorganisms, either some lipids or water, or some other exogenous toxic substances within the body. So some of those are going to interact absent receptors or not necessarily with receptors. So not all medications are going to work with receptors. I can't really find any really good examples of these, but just realize that there are some that do exist, that's what they're designed to do. There's also some antimicrobials that target specific substances that are present in the cell walls of a bacteria or a fungi. So they're not really acting on the cells, they're acting on invading cells. So they're kind of specific to what cells they'll act on. And those are, of course, antibiotics and antifungals. Antifungals are something that's relatively new. There's some chelating agents that bind with heavy metals. I'm trying to think of the, we had was it cyanide? I think it was a cyanide. Cyanide a heavy metal? I don't know. Anyway, no, cyanide's a gas, sorry. I was thinking of a cyanide antidote kit that had all these things in it, sodium thiosulfate and all that kind of stuff that was to bind with that and to get it out of the body. But basically those types of agents are actually designed to bond with the heavy metals so that they can be eliminated from the body. Now, realize some heavy metals are never eliminated from the body. Lead is never eliminated from the body. It's there. It's permanent. There's no way to get it out. And that's true with other heavy metals. And the problem with heavy metals is heavy metals are oftentimes fatal to humans. There's several heavy metals out there that are just absolutely deadly to humans in very small doses. They don't have a medication for every heavy metal out there to get it out of the body. Sodium bicarbonate's another one of those alternative mechanisms of action. What's interesting about sodium bicarbonate is it doesn't necessarily act within the cells, but what it'll do is, in the way that it binds with either oxygen or carbon dioxide within the body, to either create carbonic acid or water and CO2, and the way that it goes back and forth, which we'll talk about that later on in paramedic studies. But basically this all ties back to acid-base balance kind of stuff, which sodium bicarbonate is kind of unique in that way, and how that it has dramatic effects on the body, but yet it's not acting on specific cells, but it's causing things to happen that act on cells. So anyway, diuretics, they create osmotic changes, so they cause changes in the membranes around the areas that have a lot to do with fluid shifts, for lack of better terms. Kidneys, brain, there are some diuretics that work within the brain to pull fluids off of the brain. They're not used quite so much anymore because they found that, hey, if we got somebody with a brain injury that's got some bleeding up there as well as some swelling, if we pull fluid off the brain, then we're going to allow more room for blood. So kind of 6 of one, half a dozen of another. There are still some out there. Sodium mannitol, those types of things are some of those brain diuretics. And then, of course, we have diuretics that we use that work in the kidneys that deal with fluids and electrolytes. Realize, though, that diuretics, especially the ones that we use in the kidneys, do have a dramatic effect on not only fluids, but electrolytes. Whenever we lose fluids from the body, out of the body, whether it's sweating or vomiting or urinating or wherever we're losing fluids, we're losing electrolytes every time. The more fluids we lose, even if somebody has an overabundance of fluids, doesn't mean that they have an overabundance of electrolytes. So as you pull fluids off of somebody, we have to watch electrolytes. That's why in the pre-hospital setting, of course, in Oklahoma, the state medical director in Oklahoma doesn't allow us to give Lasix. Long story, I'll be glad to visit with you about that if you guys want to come to see me sometime, and I'll answer specific questions about that. But we want you guys need to learn Lasix and know how to use Lasix and the indications, contraindications, and everything about how Lasix works, because it is a medication that is commonly given nationwide, even though we're not using it in Oklahoma at the moment. So, Lasix, for instance, in the pre-hospital setting, it's commonly known that we're only going to give 40, at most 80 milligrams of Lasix in the pre-hospital setting. Rarely would you ever give 80, but you're going to give 40. It's because of that big fluid shift that it's going to cause. It's very effective at causing a fluid shift, but also electrolyte issues. They don't want us giving a whole lot of Lasix in the pre-hospital setting, because what if this person already has an electrolyte imbalance? Now we're going to make it worse by pulling fluids off of them. We're either going to raise concentrations of something, or we're going to lose other electrolytes through the elimination of fluids. So that's why we have to be cautious. So we have to think of both sides of the coin in any kind of medication that we're giving, and diuretics is no different. And then there's some electrolyte-based medications. They change the concentration and distribution of ions and cells in the fluid. Calcium chloride, calcium gluconate, normal saline, D5W, some of those kinds of things, half normal saline, those types of medications. And believe it or not, yes, IV fluids are technically considered a medication because you have to have a prescription to administer them. So those types of things are going to be electrolyte-based medications. Okay? There are some things that will affect how a patient responds to a medication. One of the first and foremost is the choice of the medication. For instance, a patient is going to respond differently to morphine than they will fentanyl in relatively similar doses. Sometimes just the chemical makeup of a particular medication works better with somebody than others. If you don't know it by now, we're not all exactly the same. Though we are humans, we are different. And that's not only in our appearance, but sometimes that's in our chemical makeup. Dose will also affect it. The route that we give it will affect it. The perennial route, if we're giving an injection in the muscle, under the skin, in a vein, that kind of thing. The timing with how we give it, whether we give it fast, we give it slow, whether it's slowly absorbed, rapidly absorbed, the manner of administration, how we administer it, and of course, monitoring, how we monitor that medication too. All of those things can affect how a patient responds to a medication. Age also is a little bit different depending on the medication that we give. Typically with water-soluble medications, we wind up giving infants what would be considered a higher relative dose of a medication to infants than we do adults and elderly with water-soluble medications. It has to do with their body makeup and their metabolism and how they do things. They usually get a higher dose. Now, that doesn't mean that we're going to give adults 5 milligrams and infants 10 milligrams. That's not what we're talking about. We're talking about weight-based. So where an adult might get 0.2 milligrams, an infant might get 0.3 milligrams per kilogram. So there might be that kind of a difference, and I'm just throwing numbers out there. So fat and lipid-soluble medications require higher weight-based doses in elderly people. Once again, it has to do with metabolism and how we metabolize things. So lipid-soluble medications will be a little bit different. Now, this isn't necessarily something that you're going to have to go, oh wait, that's a lipid-soluble medication. I need to change my dosing. No, it'll actually tell you that in your dosing and how that's dosed based on age. So your medication will tell you that, and it'll make an adjustment for that for you automatically. So don't go changing your medication dosages on your own. Your medical director will get very upset with you. Probably a very short career. Like I said earlier, we should titrate our medications. But this is especially true for pediatric and elderly patients. But, it points out that we should do this for pediatric and elderly patients, but I would also say any patient that you might consider as being relatively frail. So if you've got a patient that has a lot of medical conditions and medical ailments and illnesses and those kinds of things, be cautious in how you give medication to them. Take a slow approach, a little at a time, see how they respond and see how they react. Talk to the patient, if possible, and say, have you ever had this medicine before? How did it work? How much did they give you? Do you know? Sometimes they know that stuff. You might be surprised. But be careful with that when you're given medication. Their metabolism and the way that they eliminate medication. With elderly, a lot of times we look at the way that they eliminate medication. Some of it's required to be eliminated through the liver exclusively, so they can have a buildup if they have impaired liver function. Sometimes we have people that are in their 20s that have impaired liver function because of hepatitis or some kind of liver-related issue, and we need to be cautious about certain medications that we give them in the way that they're eliminated too. Patients at extremes of age are disproportionately prone to paradoxical medication reactions. So the medication will work and then they'll swing really quick the other way. So extremely young and extremely old can have some really radical changes with medication. So what we think is a therapeutic dose for them may be a toxic dose. So we have to be very, very careful and always go with the lowest or half of the lowest or a fourth of the lowest with those types of medications, and usually you're in pretty good shape. A lot of the medication that we give nowadays, especially in infants and children, is weight-based. It's where we take this medication and it's multiplied by the patient's weight in kilograms. There's some big advantages to this. Is the amount of medication is proportional to the size of the patient. The manufacturers have already calculated the factors for us. So basically they just say it's 0.1 milligrams per kilogram, and it makes it easier for us. And we can calculate those dosages for all ages. Some medications, it's the same for all ages. Other medications is, for adults, it's this many milligrams to this many milligrams. For kids, it's 0.03 milligrams per kilogram. That kind of thing. So there is some differences. So when you're getting to know your medications, and you're going to get to know your medications in this chapter or in this section, when you're getting to know them, realize that you need to know the adult pediatric dose, and when you're looking at precautions, make sure you're looking at precautions for, if there's hepatic impairments or kidney impairments or those kinds of things. If it's the very old or the very young, have elimination issues, you need to be aware of that. Limitations of weight-based medication are you need to know the patient's weight in kilograms. Oftentimes the best way to do it is ask the patient or the family member. Of course, that's not going to work with a 3-month-old, but the family member should know how much that little guy weighs. Convert that from pounds to kilograms with an easy mathematical formula. Just divide it by 2.2, or multiply it by 2.2. Sorry. The other issue with weight-based is it doesn't consider alterations in the distribution, metabolism, or elimination of medications. So weight-based, like I said, like with all other standard dosings, does not consider that there may be some metabolism or elimination issues or some liver or hepatic, all those kinds of issues may be there. We have to take those into consideration and adjust our dosages accordingly. Some of these are based on a patient's ideal weight. So we may have a 13-year-old that weighs 250 pounds. Do you treat him like an adult, or do you treat him like a child? Technically, they're a child, but they have the body of an adult. How do you do that? How would you do that? How would you give that medication? What dosage would you use? Would you use the adult dosage, or would you use the kid dosage? I would say it depends. It depends on a few factors. Why is the kid 250 pounds? Is that the normal weight for him? Has he been retaining fluid? Is he bedridden and all edematous and all that kind of stuff, to where that, there's some other factors coming into play. So there's some things that I would consider before I would just say, I would do this or I would do that. I would investigate a little bit. Also, environment affects how medications work. We're going to metabolize drugs much faster in a hypothermic environment. So if it's hot, if they're feverish, or if they're in a hot environment, that kind of things, they're going to metabolize it faster. And it may reduce the amount of drug that actually gets returned back to circulation. In cold environment, it's going to affect how these drugs are used in cardiac arrest. It's going to affect the movement of these medications. Sometimes the medications kind of get stuck in a certain place and they don't get moved through the body well. And then when we get them warmed up, all of a sudden they get slammed with all of these medications now that are starting to be circulated. So cardiac arrest patients, when they're hypothermic, we usually don't give medications, or the medications that we give are so limited. Just because their effect, oftentimes, we may see a little bit of an effect while the hypothermia is going on, but when we warm them up, the effects that we see oftentimes then are very detrimental, and sometimes we killed them with medication that we gave 30, 45 minutes ago. So hypothermia is going to affect those medications. There are also some genetic factors that come into play when we're talking about how patients respond to medications. And we need to be careful when administering medications to patients with genetic disorders, such as pulmonary hypertension, sickle cell, glucose phosphate, dehydrogenase deficiencies, whatever that is. And patients and families are usually a pretty good source of information about how particular medications work with that patient. When in doubt, call medical control. Don't just give the medication. When in doubt, call somebody. Call medical control, call your supervisor, call another paramedic with some experience, talk to them. Don't just blanketly give medications unless you go, oh my gosh, I have to give this medication, they're having a seizure. That's a little bit different. But when you have time, when you have the ability to kind of take a step back and take a breath, take that step back, take a breath. It's worth it, and it's fair to your patient. Pregnancy also, there's a whole host of issues when we talk about pregnancy. There's different things that affect the absorption and distribution and elimination of medications. Increased cardiac output, intravascular volume, respiratory tidal volume decreases, minute volumes, renal blood flow, urinary eliminations, all those kind of things come into play. They have a decreased hematocrit. Inspiratory and expiratory reserve volumes are different gastric mobilities. There's a change in the endocrine glands. Pregnancy has a lot of an effect on medications, and those medications have a dramatic effect on a growing fetus. So there's a whole host of things we need to consider when we're talking about medications. One of the things that we need to ask females that are in those childbearing years is there a chance that you're pregnant? Make sure that the medication that we're giving them isn't going to be harmful to them. Now, a patient that is unresponsive in a life or death situation, and it's a medication that you need to give to save their life, give the medication. Don't worry about pregnancy and those kinds of things. Give the medication. Mom dies, baby dies. So that's the kind of the approach you need to have. All right. So, and this is just kind of a list of pregnancy letter categories that tells us when we should give it. So A is usually okay, but as we work down the list, it gets worse, and it's going to tell us, not to use it. So we get down to D. It says there's positive evidence of fetal human risk, but the benefits from the use in pregnant women may be acceptable despite the risk. So D, it says maybe some risk, but may be worthwhile. X says give it. It just says there's no benefit that's going to outweigh the risk. None. And that's what that X category is. A is good, and as we work down the list, you can kind of see how things change. Okay? All right. So when we talk about pregnancy, we're talking about pregnant moms, including labor and delivery. So mom has got the baby bump, and then labor and delivery is part of pregnancy. Breastfeeding is part of pregnancy. And then male and female users that are trying to have a baby, because it can affect that fetus before it's even formed, before contact so to speak, is even made. So you have to be cautious of that. There's also some psychosocial factors such as pain, anxiety, discomfort, how that's different among patients. Watch for verbal and nonverbal cues. Watch your patient. You give them medication, don't just think everything's going to work out and be hunky-dory. Watch them. Keep an eye on them. Talk to them. Say, you feeling okay? You feel all right? What okay? One of the funniest things that I had happen to me, I had a little man, he was in his 70s. He was having some chest pain. And we picked him up. I gave him a little spray of nitro. Didn't really relieve his chest pain. So, and it looked like he was having an MI. So we just kind of moved down the list of things. I get him in the back of the ambulance. We're kind of moving because he's got some pretty good indications that he's having an MI. Get him in the back of the truck, and I get my baby aspirin out, and I said, here, take these. I said, chew 2 of them up and put 2 of them under your tongue. And while he was doing that, I'd already started an IV, so he chews 2 of them up, puts 2 of them under his tongue, and I gave him just like 2 milligrams of morphine while he was taking the aspirin. And I'm just kind of watching him and, kind of jotting down, making some notes about, times and all that stuff that I give him his medication. So I'm looking down at my paper, and he goes, excuse me, son. Excuse me, son. And I said, yes, sir. And he's just got this smile from ear to ear on his face, and his color's looking a lot better and all that. And he goes, and he reaches out and he puts his hand on my leg, and he kind of leans up, kind of closer up to me, and he goes, tell me, where do you get your baby aspirin? Those are the best aspirin I've ever had. And actually, it was the morphine. He had no idea that it was the morphine that had caused that. But watch those verbal and nonverbal cues. I could tell that the morphine relieved his anxiety. Probably the nitro had started to work and caused some vasodilation. And we were making progress. We were moving in the right direction. Sometimes medication administration is complicated by the placebo effect. Just the fact that you're giving them something, they think they're better, when in reality is you really haven't done anything to fix it. So watch out for that placebo effect. And I'm not talking about a placebo effect where you're trying to pull the wool over your patient's eyes and give them normosaline instead of something. You're giving them normal saline. You're calling it normosaline and making them think they're getting, morphine or something great. I'm not talking about something like that, which actually that's illegal to do, by the way. But where you give them a medication and they think just because you've given them a medication that they should be feeling better, and they do. When in reality is the truth is it's really not. That's not the case. That's not what's going on. It's kind of a placebo, and they may have a return to that. All right. So types of responses, the first one we have is we have a therapeutic response, or a desired response, or a desired effect. It means that medication actually worked. We selected it based on the patient's illness, injury, complaint, signs, symptoms, age, all that kind of stuff, and the doggone thing worked. It should have worked because it matched the use and indication that was listed in the medication profile. It worked fine. If we gave the right dose, we gave the doses it was supposed to be given. Maybe even had to repeat it. And of course, these therapeutic effects also have the ability of demonstrating some cumulative action. But we may also have some adverse effects. Be ready for therapeutic and adverse effects in the same patient. So sometimes we'll have a reaction, we'll have some changes, some clinical changes that are not desired. That may cause harm or discomfort. Most of the time it's discomfort. Sometimes it's harm to the patient. Sometimes you give them a pain medication and they don't like the way it makes them feel. They don't like that feeling of not being in control, or that floating or lightheaded feeling. That would be an adverse reaction for that patient. Consider this in relation to their condition. Patients with chronic medical conditions seem to be more susceptible to adverse reactions, and patients may be unable to tolerate even mild adverse reactions. They just might not be able to stand it. Regardless of the benefit of the medication, they just might not be able to handle the adversity of the reactions to that medication. These may range in severity. Side effects can be desirable in certain situations and harmful in others. And they can be completely unexpected. They can be any idiosyncratic medication reaction. So completely unrelated. I mean, it's like, wow, where did that come from? I did not see that coming. So keep an eye out for those adverse reactions. So there is a therapeutic index, and what that means is that is the dose of medication that is therapeutic. It's not necessarily the patient's therapeutic index. This has everything to do with the dose of the medication. So if we take the median lethal dose, meaning the amount of medication that causes half of the animals that we tested this on to die, so we take that dose, and then we've got a toxic dose, which is the dose at or above which causes toxic effects. So we take the lethal dose and the toxic dose and the median effective dose. So we've got those three doses in this therapeutic index. So we have a fatal dose, toxic dose. A fatal dose means kill you. A toxic dose means go make you sick, probably in a bad way. And then we've got the median effective dose, so the dose that it's effective in that median range. So that's that therapeutic index. Now, we take that index and we look at the relationship between the median effective dose and the median lethal dose. If there's a large difference between the median effective dose and the median lethal dose, then we consider the medication as safe. So what I'm saying is, if the therapeutic dose is 5 milligrams, if most patients, if half of the patients that get 5 milligrams of that drug see resolution, or they have a therapeutic, it seems to work for them, it's, the dose is therapeutic. If that is only 5 milligrams, but 150 milligrams is lethal, then we would consider that medication safe, because most of the time we're only going to give 5 milligrams. It's going to take 150 milligrams to kill somebody. Okay? So that medication we would consider reasonably safe. Now, if there's a small difference in the therapeutic index, it means that the patient needs to be monitored. So if the therapeutic dose is 5 milligrams, but the fatal dose is 10 milligrams, we got to watch the patient close, because therapeutic for one may be fatal for another when there's that close of a relationship between the median effective dose and the median lethal dose. Hopefully that makes sense. So those medications that when we give them, we have to monitor them every 1, 2, 3, 4, or 5 minutes. Those are those that have a very small difference in what can be lethal, or has the potential to be lethal. So that's that therapeutic index relationship. There are also some immune-mediated responses. Sometimes genetically predisposed patients have initial exposure and sensitization. They get sensitive to a medicine, right? They have an allergic reaction. Basically is what this is talking about. And this sensitivity may follow a first exposure. So the first time they're given penicillin, they kind of have this rashy allergic reaction, and they're given Benadryl, maybe seen in the emergency room. The problem is they develop a sensitization to the allergen. And if there's a subsequent dose of that, it's probably going to be fatal, or it will be near fatal. And those are the ones that will carry around an EpiPen, probably not for the penicillin ones, but peanuts, allergic to bees, carrying around an EpiPen, because the first exposure said, hey, look, if this happens again, it's probably going to kill you if you don't have Epi. So immune-mediated responses, sometimes medications, patients are going to have allergic reactions to them. We've got to be prepared for that, and we've got to watch it. That's why it's important to talk to your patients. Have you ever had this medicine before? Have you ever been given this before? No. Okay, well, I know I need to watch. Or, yeah, I've had that several times. It's, I've never had a problem with it. It should be fine. So, also, patients begin to develop a tolerance, or that these medications have a decreased efficiency when taken repeatedly. I know we always think of this in terms of narcotics, but this is also true with a lot of other medications, respiratory medications, and those different types of things that are completely non-narcotic related. It's just that the body begins to get tolerant of those. That's why sometimes in the pharmaceutical industry we have several medications that kind of do the same thing, but they're a little bit different chemically. So when a patient starts to get a tolerance to one, we can switch them to another and continue to have the same therapeutic effects that we're looking for. Sometimes tolerance also results from downregulation, which reduces the availability of cell receptors. It just gets overly stimulated or whatever, and we lose receptors from that. I was trying to think. I had a good example, and it just kind of eluded me of where we get we lose sensitivity. Actually, part of the addiction to narcotics is related to this downregulation, meaning we have all of this. When narcotics causes a release of dopamine in the brain, which is that feel-good chemical in the brain, it causes an abundant release of dopamine. So they keep taking this narcotic so they can have this feel-good feeling. Well, the brain starts to recognize, hey, there's too much dopamine hanging around here. We need to stop producing dopamine or reduce the number of dopamine receptors in the brain. So the brain starts to downregulate that. And as an addict, what they do is while they're trying to seek that high, they start taking more and more of that drug to release the dopamine. Well, eventually they reach that tipping point of where they're downregulated so much of dopamine or dopamine receptors that those have been downregulated just by natural process of the body going, hey, look, this is a little too much. They wind up overdosing on the medication trying to get that dopamine high feeling. So that's what happens with the tolerance. Also, sometimes we have cross tolerances. Sometimes repeated exposure with one class has the potential to cause problems with the other class, meaning sometimes other drugs are going to react differently because of another drug that they've been given or they've been taking a while. Tachyphylaxis is repeated doses with a short time rapidly can cause some tolerance. So taking a medication rapidly can get a tolerance quickly. This is true with narcotics. Sometimes patients that legitimately need narcotics and legitimately need pain medication, and they have to have it in quick succession for a day or two, they can rapidly get a tolerance to that medication and need more. Of course, abuse and dependence is always the thing that we're worried about. Stimulants, depressants, narcotics, those kinds of things are all susceptible to dependence. Repeated exposure can, it's one thing to be mentally dependent on it, to say, hey, I want this drug, and that's where the addiction starts, is mentally you want that feel-good feeling, but then eventually your body begins to get a chemical addiction to it, where it needs it. Stepping back to the narcotic analogy, where we're taking this narcotic that we're not supposed to be taking, and it's causing the release of dopamine in the brain. Well, and the brain has reduced the number of dopamine receptors and reduced the amount of dopamine that's being released. So thereby, we want to take more narcotic for that, and we've eliminated the dopamine release and the dopamine receptors way down. Well, now we want to quit. We want to quit using that drug. Well, we try to quit using that drug, and our body's craving it so badly because it's what's going to stimulate the release of dopamine. Now we have no dopamine release. And the receptors are all, when you're chemically in your body returns to normal, there's, a fourth or however many number of dopamine receptors, and the release of dopamine is so dramatically decreased that you're now chemically dependent upon that particular drug. And of course, prolonged or significant exposure can cause dependence. Some people can become chemically dependent in a short amount of time. It's surprising. Of course, there's some interactions. Some of these interactions are undesirable. Some interactions are actually desirable. Sometimes we use medications that kind of had a synergistic effect that work together, and we use it to our benefit. Actually, Lortabs are one of those. They tried to take Tylenol out of Lortabs, out of the hydrocodone. They tried to separate the two, and they found that hydrocodone was less effective absent Tylenol. So the two of those kind of had a synergistic effect where they worked well together. The reason why they were trying to take Tylenol out of hydrocodone or out of Lortabs and those types of things was people were abusing these things, and they were taking a bunch of them, and they were overdosing on Tylenol. Tylenol is all eliminated through the liver, so they're causing massive liver damage. So not only do they have a chemical dependency, but now they've got massive liver damage from all of this Tylenol that they're taking because they're overdosing on these things. So there are some good and bad reactions to these medications. Some of them just may decrease or increase or alter the effect of another medication, good, bad, or indifferent. So it's not all bad. All right. So when we give a medication in the body, the body automatically begins trying to get rid of it. And how long that medication stays in the body is dependent upon the dose, how it's administered, and the status of the patient, the relative health of the patient is how that medication stays in or is eliminated from the body. The pharmacokinetic section of a medication profile states the onset, the peak, and the duration of a medication. So how long it's going to take for it to be completely absorbed and distributed throughout the body is the onset. The peak of its effect is the relative to absorption and distribution right before it starts the elimination process. How long it's going to be in the body is relative to the metabolism and elimination of it. So onset, peak, and duration are all important terms that we need to know about our medications. How long is it going to take for it to work? When am I going to get a peak effect from it? And how long is it going to last? All are important things to know. Good or bad. You give somebody a paralytic and can't get them intubated, you want to know all of those things. Because now you need to know how long you're in for. All right? So, routes of medication. The route of medication administration must allow the delivery of the appropriate amount of medication to the correct location. So, you can't just give any medication through any route. It needs to be the correct route for the effect that you're trying to get. This is determined by physical and chemical properties, the routes that are available, how quickly the effects are needed, the bioavailability or the percentage of unchanged medication that reaches the systemic circulation, which is going to vary by medication, and a lot of other factors. So, all of these oral gastric and nasogastric tubes is the first route that we're going to talk about. The patient must be responsive, or they need to have an NG tube, have the ability to swallow, or like I said, they need to have that. This is one of the slowest routes that we can administer a drug. It takes a while for that medication to be absorbed. It can be 30 minutes, 40 minutes to hours. It all depends on also if they have food in their stomach or their stomach's empty. A lot of factors come into play when it comes to GI medication. Medication give endotracheally, where we've got a patient intubated and we want to give medication down the ET tube into the lungs. This is no longer considered a reliable method. At one time it was very highly touted. It's no longer considered. But if we must do it, you must administer 2 to 2.5 times of the dose. Problem is that winds up being a lot of fluid because we have to follow that with 5 to 10 milliliter flush of sterile water. So now we're dumping a ton of water in there on their lungs. Not something that's usually a good idea in somebody that we have intubated, because we've got them intubated probably because there's some kind of respiratory issue, right? Now we're going to dump a lot of medications and fluids and stuff into their lungs. Another reason why this is no longer a viable route is because we can just get an IO. If we can't get an IV, just put an IO. Intranasal is a good route. We use this a lot of times with seizure patients with a nasal mister. Liquid medications are converted into a mist that's sprayed into one or both nostrils. Rapid absorption bioavailability is close to 100%, almost as good as injecting it in a vein. There's no risk for needle stick injuries when you're trying to needle in somebody that's having a seizure and they're kind of flopping around. You don't have to worry about getting stuck. Intravenous is the preferred method for us in the pre-hospital setting. We have that catheter that's inserted into a peripheral or external jugular. Bioavailability is 100%. Quick onset, usually seconds to minutes. Have a pretty quick onset depending on the drug. Limitations, sometimes it's tough to get an IV on some patients. Pain, anxiety, infection, it's a little bit more time consuming to get done. Certain classes of medication can cause pain and tissue damage when we administer an IV. So there's some considerations with the medication we give. IO, another great route, an easy route for us to get. Of course, put a needle into the bone. I imagine all of you guys are familiar with this. Can leave that in usually up to about 24 hours. After that, it needs to come out. Hopefully, there's a better route. If not, they should be in a hospital by then. Maybe they can put a subclavian in or something like that. It's a little more permanent. Can't put it in any bone that's fractured, or if there's a bone fracture proximal to that. So tib-fib's okay, but broken femur, don't put it in that side. Put it in the other side. Hopefully there's some good bone there and nothing broken. IM medication is injected into a large muscle. Bioavailability is 75 to 100% depending on the medication. Make sure that the medication is appropriate for IM use, and usually it says it right on the medication vial. There are particular muscle groups that should be used when giving medications. Depending on the amount of medication that you're giving and the type of medication that you're giving, will kind of help determine which muscle group you should use. And a particular technique will be used for giving those types of injections. Sub-Q medications is injected in the subcutaneous tissue just below the skin. Some medications are indicated for that use. It's a little bit slower. That helps prevent some adverse cardiovascular effects. So, for instance, if we're giving subcutaneous epinephrine for someone that's having a breathing problem or an anaphylactic problem, we don't really want any cardiovascular effects, or we want to limit the cardiovascular effects. We can give it subcutaneously and reduce the likelihood of having a whole lot of cardiovascular effects with that medication. Dermal and transdermal, another effective route, but it's a long-term route. Usually this route is for something that's going to be, we don't have to have rapid treatment, but we want long-term treatment. These are usually medication patches. Why is it important that you know about medication patches? It's because you need to make sure you do a thorough assessment and look for medication patches. These may alter a patient's clinical presentation or interfere with other medications that are being administered. This give a relatively constant dose during a prolonged period. These often contain a large quantity of medication. You'll see people with fentanyl patches in their mouth, dead in their mouth because they've overdosed on them. They put them in their mouth and chewed on them and killed them. So sublingual route, medication is placed under the tongue. Nitro is one that comes to mind for that. There's some others though. Bioavailability is low. Larger doses are required, which is surprising because the dose for nitro is low, 0.04 milligrams per spray, but actually that's kind of high. Patients must be conscious and alert, and of course it says that's how we give nitro. Inhaled or nebulized medication, limited to oxygen and antidotes. What? I'm not sure. Inhaled or nebulized may assist patients with medications via metered dose inhalers. Liquid nebulization has a potential for bronchial spasms. Actually, a lot of the medications that we're going to use that's nebulized is usually to treat respiratory problems and to treat bronchial spasms. So don't let this mislead you too much. Rectal route is actually preferred if the patient is unresponsive, having seizures, vomiting, or unable to swallow, ironically enough. May have greater than 90% bioavailability, so it has a high bioavailability. Manufactures in suppository form, but it can have some unpredictable absorption rate, so it's not the perfect thing. Ophthalmic into the eyes, different agents, anesthetic agents, or eye drops and that kind of stuff is a route. Not one that we typically use unless we're just flushing the eyes out. We're not usually giving a medication that route. Other methods, of course, hemodialysis, we also need to be sure we're not using any routes that we're not specifically trained to use. So if somebody's got a PICC line or a triple lumen or that kind of thing, don't use those unless you've been trained to use those. We'll talk about those some as we progress through the course. We're probably not going to be able to hit all of those, and I'm not really sure that you're going to remember those particular things. So we're a little cautious about talking about specific devices for you to administer things through. There are those indwelling devices especially, so those are a little different. They require some specific training, and that may be taken care of either at your service or through a higher level class such as critical care, paramedic, and those kinds of things. So try not to get too disappointed if we don't teach you about triple lumens or PICC lines in here, just because it's kind of one of the things. It's time and a place, and we don't want to throw too much at you too quick, too early, and expect you to learn too much. And sometimes you'll latch on to things that are actually less important than what you really need to know. So we try not to muddy the waters. Distribution medication. How a medication moves through the body is determined by the chemical properties of that medication, physical properties of the patient, and several other patient factors. There's a number of barriers that prevent the induction of foreign substances to different areas of the body. And medications must also be able to move through these barriers. Sometimes osmosis is used to enhance the distribution of certain medications, such as mixing a medication with IV fluids to either leave that medication in the intravascular space or get it to the cells and tissues. So some medications will say, hey, this medication needs to be mixed with D5W, or this medication needs to be mixed with normal saline, or in the case of Dilantin, we say never mix it with D5W because it'll turn to gel. Sometimes we'll use IV fluids, D5 half normal or half normal saline, those types of things to affect how a medication is delivered, or it stays in the vascular space, or it's delivered to the cells. Not going to be a huge issue with you guys at this level, but I point it out because, when you go do your hospital clinicals and those types of things, when a physician orders, hey, I want this drug mixed with half normal saline, there's a reason why they're doing that. They're wanting that fluid to really stay in the intravascular space and not so much get to the cells right away. So they're doing some things for those purposes. Filtration, of course, is the process within the body that is used to redistribute water and other particles. Hydrostatic pressure forces various fluids against the semipermeable membranes, and we use these things, we mix medications with different fluids, knowing these things so that we can get the medications where we need them to be and kind of help keep them out where they shouldn't be. Epithelial cells create a continuous barrier. There's these small non-ionic lipophobic molecules that can pass easily through those cell membranes, though. The larger hydrophiliac and ionic molecules must find another route. So some things that we can give on top of the surface go through relatively easy. Other things is going to take a whole lot more work to get those things through the surface of the skin. These medications, once they're in the body, their journey's not over. They must be able to get through the capillary walls and reach some of the tissues, especially the target tissues. And there's some barriers to that. There's the blood-brain barrier, the blood-placental barrier, the blood-testicle barrier. Those barriers they're not like physical walls, but they're physical protections upon those areas where the blood flows into there. They're protected, that keep those kinds of things out, that basically pull them out of the blood circulation so they can't get in there. One of the things that Parkinson's disease is a dopamine deficiency. And the medications that they give people in order to counteract that actually stimulates the release of dopamine in the brain, but by doing so it actually stimulates the release of dopamine in all areas of the brain, and it causes that kind of that jerky Parkinson's-like movement. Well, the problem is they can't fix this problem because they can't get dopamine directly into the brain. They can't give somebody dopamine and it go to the brain. It doesn't work like that. The blood-brain barrier keeps dopamine that's in the blood circulation from getting to the cells in the brain. That's the blood-brain barrier. One of the drugs that they had developed that had a small amount of success was called levodopa or L-dopa, and they would give this drug, it would get past the blood-brain barrier, and then it would convert into dopamine inside of the brain. Worked great for a while, but eventually the effects would start to wane, and within a few weeks or months, it was no longer working for those patients. So, blood-placental barrier, which is designed to protect the fetus, and the testy barrier, which is designed to protect the reproductive cells in similar ways, and similar things will or won't get in there. Blood typically passes freely through capillaries in the kidneys, the thyroid, the pancreas, lungs, and the peritoneum, though. There's some plasma protein binding that may happen with some medications. These medications may latch onto a molecule or a protein in the blood plasma and be circulated around the body. As the concentration of medications change, the blood plasma protein levels change as well. Or if another medication that binds with plasma protein is introduced. One of the medications that does this is warfarin. Warfarin actually latches onto a plasma protein and floats around the body. Part of the reason why it needs to be heavily monitored and regulated with blood levels, they need to do protons and all that kind of stuff and see where the level of that is. All right, lipophobic medications can be sequestered into fat tissues of an obese person. And then these medications can be slowly released, causing prolonged effects. So maybe something we intentionally do, and it may be something we don't intentionally do. One way or the other. Volume of distribution basically describes the extent to which a medication will spread throughout the body. Medications with lower volume of distribution have higher levels present in the plasma. So, and then of course the biotransformation is what happens when the medication turns into a metabolite. Active metabolites are capable of pharmacological activity. Inactive metabolites no longer possess the availability to alter cell activity. Some medications, as they break down into active and inactive metabolites. The active metabolites will actually have an effect. The inactive ones won't. And then as it's further broken down, those active metabolites may be broken down into more inactive, and then eventually eliminated. Possible effects of biotransformation: an inactive substance can become active. So somebody's given a substance, kind of like L-Dopa, like I talked about, as it's metabolized in the brain and broken down, it becomes active. So it breaks it down into active metabolites. Or an active medication can be changed into another active medication. So we have a medication, it's active, and then it's broken down and it's active in another way. So kind of like a pyramid kind of thing. And obviously an active medication can be inactivated. An active medication can be transformed into a substance that's easier to eliminate. This is all about the scienciness of the pharmaceutical companies and the medications that they create and the things that they take into consideration when they're creating a medication. Well, we can't get a medication that's going to directly do this, but can we create a medication that can go in, be metabolized, and then do that? And if we do that, how's that medication then metabolized and eliminated? How hard is it to get out? Because that's going to affect the bioavailability of that medication and how long that medication stays in the body. So you want to know the elimination rate. So all of those things come into a factor when they're developing new medications. A lot of biotransformation actually occurs in the liver. The P450 system alters the chemical structure of medication. So the system within the liver actually begins to break down and change the transformation of the liver. Actually, the kidneys, skin, lungs, GI tract, and other tissues may also cause some biotransformation, but most of it happens in the liver. And this biotransformation actually makes the medications easier to eliminate. Not necessarily an intended consequence, but it's part of what the body does is to break down this stuff to get rid of it. Remember what I told you was, when we started out, nearly every medication that we give is poison to the body, and the body wants to get rid of it. So the body is intentionally trying to break down this stuff and get rid of it. That's the constant battle. That's why some of us have to take a blood pressure medicine every day, a blood pressure pill every day, sometimes twice a day, because the body is working to get rid of that medicine. But that medicine is actually doing a good purpose, but the body's trying to get rid of it the whole time because it sees it as a toxin. It sees it as a poison. There are some medications that are primarily removed by the kidneys. Actually, we back up. Biotransformation typically happens in the liver, so these things are broken down in the liver and eliminated by the kidneys. So they're broken down into these component parts that are ultimately gotten rid of by the kidneys. Of course, there's a variety of factors that's going to affect how quickly they're eliminated. How well the kidneys are functioning, the fluid levels in the bodies, and all that kind of stuff, electrolytes. Two patterns of it is zero. First one is zero order, a fixed amount of substances removed during a certain period. And first order elimination is the rate of elimination is influenced by the substance's plasma level. So it all depends on the drug and how it's eliminated, the concentration of it, how quickly it's eliminated, if it's plasma carried or whatever that's going to happen, that's going to cause that. When you hear half-life referred to is that is the time it takes for half of that particular drug to be in plasma to be eliminated. So the half-life of a particular drug is, this is how long it takes for it to be eliminated from the, half of that drug to be eliminated from the body. Of course, this can be affected by disease states such as liver issues, changes in perfusion, interactions with other medications, and those types of things can affect the half-life of a drug. Medications are administered at a dose and frequency equal to the body's rate of administration. So what they do is when they determine the dosage amount and how often repeated dosage need to be taken every 2, 4, 6, 15 minutes, hours, whatever, this is the thing that they take into consideration, and they're using what they basically consider is, all things being equal, all things being normal, it takes this long for this drug to be eliminated, and redosing needs to occur within this time frame in order for the therapeutic dose to be maintained. And of course, even small amounts of medication can be eliminated in expired air, ironically enough, as odd as that seems. So, one of the things we need to make sure that we do, one of the many things, is we need to make sure that we are very careful and we watch out for medication errors. Medication decisions in the field as paramedics are often done purely off of memory, and usually in the context of a very stressful, life-threatening situation. This could make it very easy for us paramedics to make a mental error. One of the things that we try to do is we try to get you in the lab and we try to get you using these medications, and we try to stress you a little bit in using these medications and get you a little frustrated so that you start to get used to pulling out this information while you're stressed, and you start to get used to just being stressed, and how to deal with that, how to handle that, and how to respond to it. So that's something that we've got to be aware of. So anytime, whenever you are in doubt, look the cotton picking dosage up or phone a friend. Don't just do it. Don't just give it. So the way we reduce medication errors is we use all the rights. The right patient, right medication, right dose, right route, right time, right documentation and reporting, right assessment, right to refuse, right evaluation, and right patient education. So we don't just grab a drug and give it to a patient. We want to make sure that we're using the right drug, we've got the right dose selected, we're going to give it the right way, we're doing it at the right time. We have evaluated the patient right, we've assessed them right, we've given the patient, we've educated the patient, and we've given them an opportunity to refuse the medication. Odd as it may seem, patients need to know what you're doing. Don't just grab a medication and give it to them like I did with the morphine for the poor little old guy that thought the baby aspirin was the miracle drug. Make sure that you're informing your patients of what you're doing before you do it. If you let them know, say, hey, look, I'm going to give you this medication. Oftentimes patients say they have this kind of a reaction. If you feel that way, it's okay. It's normal. So that way you're talking to them, you're talking them through that. But that's a way that we can reduce errors. Whenever we get verbal orders, make sure that we read those orders back exactly as they're given to us, and I would write them down at the same time and read them back. Call out the medication name and dose. Make sure that we label our syringes when we draw medication up so we know what's in that syringe when we set it down and we've got to go back to it later. Bring the patient's medications with us. Bring the pill bottles with us. Don't just make a list. Bring them with us. It's very easy to be thinking one medication, looking at a medication on a pill bottle and write the wrong thing down. Bring the medications with you. Make sure you're using a reliable reference source, and have your partner confirm the dose. I know this seems very weird. This is something in a big part of the culture of safety and EMS that we're starting to push for. Have your partner, even if they are an EMT basic, like you guys are right now, confirm the dose. Hold that, show them that medication, say, this is Lasix. There's 40 milligrams of Lasix in 2 milliliters. I'm going to give them 20 milligrams. That's 1 milliliter. Do you agree? And they look at it and go, yep, I agree. They're not agreeing that we should be given that medication. They're not agreeing that it's the right dose to give. They're just confirming what you're thinking in your head that you want to give. So it's not like you're asking your partner to give you permission to give a particular medication. You're just confirming what you're thinking. You're confirming your logic with them. They may go, no, wait. This is 40 milligrams in 4 mils. So you would only be giving them 10. Oh, yeah, you're right. I need to give them 2 mils instead of 1. So that's why we need to confirm that. It's very easy to make mistakes. All right, so that's part 1. I will get started on part 2 here in just a little bit, and you guys will hear more from me then.